Perfect. All right. So welcome everyone. Good afternoon. My name is Leopoldo Cavazza, and along with Byron Powell, I'm the co-director of the Center for Mental Health Services Research. And welcome to our monthly CMHSR monthly seminars. And today we have a great speaker, someone that I've known now for 3 years, Dunni, in many ways, from the beginning of your K Award idea to your K Award, which is always exciting. So today we have Dr. Oluwoye. She is an assistant professor at the Elson Floyd College of Medicine at Washington State University. She's also the co-director of the Washington State Center for Excellence in Early Psychosis. Her work focuses on increasing racial and health equity in substance use and mental health treatment, with an emphasis on improving access to treatment and treatment delivery for racial and ethnic minority youth and their families. Today, she's going to present some of the work that she's been doing currently in her Career Development Award. She has an NIMH-K01 award, which is in your second year, right? Yep. Which is exciting. Then her current project seeks to develop a family engagement intervention for coordinated specialty care program for first episode psychosis. And today she will be presenting her work examining barriers to family engaging in mental health services for first episode psychosis. And I've always admired Dunni's work in this area. She's really carving a very specific area of really examining racial and ethnic disparities in early intervention services for first episode psychosis, and she's done some great work. Her paper in psychiatric services that uses the race connection data really provided a real entry point into this area and highlighted some very important findings for the field. So with further ado, I give you Dunni and take it away. You can share your slides now.
Let me figure myself out. Okay. All right, so I appreciate being here today. I'm excited to present this research with you all. And so, Leah, thank you for the introduction on that. I always like to see who is on here, so let me make, while I'm presenting, to see if I'm missing the mark or hitting the mark for people's faces. So as Leah mentioned, I will be presenting some preliminary findings from my K01, my NIMH-funded K01, that really looks at the barriers to family engagement or family participation in their pathway to care and to receiving mental health services in the form of coordinated specialty care programs in the US. And so I'm just gonna start off by giving you a little bit of a background, because I think sometimes I'm so into this world that when I start describing it, people really don't know what I'm talking about in terms of coordinated specialty care programs. And so with that being said, schizophrenia spectrum disorders are one of the most disabling and the leading causes for premature mortality among all medical disorders within the United States. And of individuals that are diagnosed with the schizophrenia spectrum disorder, approximately 120,000 individuals in the United States will experience their first episode of psychosis. And what that means is essentially, actually, I'm not going to go into all of that. In terms of first episode psychosis, males tend to experience first episode psychosis earlier than females, where males tend to exhibit symptoms during the ages of 15 to 20 years old, where females usually experience their first episode of psychosis between the ages of 20 to 25. And a lot of those experiences occur before the age of 25. And so a lot of the times when you're looking at the literature and they're referring to youth, they're including this large age range that includes young adults as well. In the United States, the duration of untreated psychosis is approximately 20 months. And I think this point is extremely important, because duration of untreated psychosis is a strong predictor for clinical outcomes when individuals enter into early intervention programs for first episode psychosis. And according to the World Health Organization, they really want that number to be around 3 months for individuals from the development of their symptoms, which is usually marked by hallucinations or delusions, to when it is that they enter early intervention programs, or when it is that when they start appropriate medications. And so duration of untreated psychosis can be measured in different ways. And in the way that I'm going to use it moving forward and throughout this presentation is really the development of these symptoms to the initiation of early intervention programs for psychosis. So what are early intervention programs for psychosis? In the United States, we call them coordinated specialty care programs. And they include multiple different components in order to deliver that to an individual, where the multiple different components include supported education and employment, helping individuals who have goals of going back to school or who have goals of getting a job, family psychoeducation, individual resilience therapy, which is the individual therapy component attached to coordinated specialty care, medication management, where they're actively involved in the medications it is that they're prescribed by a psychiatrist or a nurse practitioner. Some coordinated specialty care models also include peer support and case management. And I think as the field grows, we'll start to see more and more elements added to coordinated specialty care programs. And so essentially, when individuals enter these early intervention programs, they receive the bundle of services, where they're going to individual resilience therapy about once a week, where family psychoeducation is provided to family members once a month, where an individual can also participate in family psychoeducation, supported education and employment. They're also seeing them frequently, and they're seeing a prescriber or a medical professional in terms of their medication to monitor their medication to make sure it's the right fit at least once a month. And so we really provide these bundles of services that it's, as you can see on the slides, that's multi-component and it's multidisciplinary with all the different behavioral health stuff that are included on a team. And so in 2008, the National Institute of Mental Health funded a large randomized clustered trial that really sought to look at do coordinated specialty care programs in the US by creating this bundle of services. Does it have a positive outcome or impact on individuals that enter that program? And the reason why we want to do that is essentially because if you leave schizophrenia or individuals that are diagnosed with schizophrenia spectrum disorder untreated, it's very taxing on our mental health system, on our medical system, but they have worse outcomes. You have increased hospitalizations, you have more interactions with the criminal justice system, you have increased rates of homelessness, and you have increased mortality as well. And so that's essentially the reason why NIMH decided to fund this trial that looked at coordinated specialty care programs. And so one of the big things that came out of that is that this program did have a positive impact on clinical outcomes as well as functional outcomes. When you include quality of life and getting individuals back in school and maintaining work. And so from that study, there was additional funding that was distributed federally. So now that in the United States, as of maybe like a year or earlier this year, we have over 300 coordinated specialty care programs distributed throughout the United States. And there are different versions of those coordinated specialty care programs where you may be familiar with things such as On Track New York, which is a specific model for coordinated specialty care. Navigate is the actual model that the National Institute of Mental Health funded. And then another common model is ESA. And so as time has been progressing, here in Washington State, we started out with a Navigate coordinated specialty care program, but over time we've added certain elements. And so we really call this a hybrid model for coordinated specialty care programs. So why do family members matter? Why do family members matter in terms of coordinated specialty care if they're essentially developed to provide services for individuals or youth? So family members play, and I'm pretty sure a lot of you know, they play a key role in facilitating the pathway to mental health services. They provide additional support for individuals, especially because about 88% of individuals within coordinated specialty care reside with a family member. But if you just think about it in terms of when you were in your adolescence or early 20s and you were living at home with your parents, they were also responsible for making sure you get to appointments on time, to making sure, it's directly linked and associated with the engagement of individuals. So it's important to engage family members because it's associated with the engagement of individuals in these programs. But what we also know is that the lack of family engagement, if we look at prior to our experiences prior to care, that the lack of family engagement is associated with negative short and long-term outcomes. So specifically, in several studies that we have conducted, where Leanna and I have really pulled data from that RAISE study, that NIMH study that I had mentioned, is that limited family engagement prior to or no contact with a provider or mental health professional prior to the initiation of early intervention programs, for Black individuals specifically, led to poorer quality of life outcomes within treatment. And so what that's telling us is, for Black individuals and for Black families, it's extremely important to engage family members early because it's directly associated with their quality of life outcomes while they're in treatment for early psychosis. Another part of that is initial engagement. Engagement can be viewed in multiple different ways. You can take a look at engagement on their pathway to early intervention programs. You can look at engagement at that initial appointment, that first appointment, and then you can look at continuous engagement across the 2 years of early intervention services that they have. From using data from Washington State, we were able to look at if a family member was engaged in that initial first appointment, was that a predictor for continuous engagement? And yes, it was a predictor. So hooking families in immediately during that first appointment is essential to their continuous engagement, not only for the family member, but also for the individual. And I'm going to talk a little bit more about that last point about initial engagement and continuous engagement, and how the pathways to care really impacts that initial engagement and the continuous engagement moving forward. So using the data that you can really access, anybody can actually get access to this data through the NIMH data archives that makes clinical trial data publicly accessible, so you can use it and analyze that data. So we were able to pull that data and really look at service utilization. And so what you're looking at here is on my left anyways, I hope it's your left too, but on the left-hand side, we see community care, which is the control condition within this large trial. And then we see Navigate, which is the coordinated specialty care in the treatment group. And what we're looking at is the engagement of family members in that family psychoeducation component of coordinated specialty care programs. And we're looking at it by race and ethnicity. Two things that are extremely striking. A, Navigate and coordinated specialty care programs engage families more, which we can see looking at these two figures. Community mental health programs or standard care behavioral health programs, the engagement is extremely low. It's less than 10% across all racial and ethnic groups. But even in Navigate, for an intervention that is impactful, that shows positive outcomes for families, for individuals anyways, we see that engagement is less than 50% over time. And this is over a 2-year period of early intervention programs. And what was the most striking thing is that African American and Black families were significantly less likely to be engaged in family psychoeducation and in coordinated specialty care programs compared to white individuals. And so this was really, as Leo had mentioned a little bit earlier, this was really the data that I used to propose my K01, my NIMH-funded K01, and it really kind of built off this racial and ethnic disparity that we found in family engagement and overall just low family engagement in coordinated specialty care programs, especially since now that there is over 300 programs, we really need to figure out and understand individuals' pathways to services for early psychosis and improve family engagement in coordinated specialty care programs. So essentially, this is what I will be doing in my my K01. And it's in 3 phases. We've just recently started the beginning of phase 2. And I will be presenting you some findings from our phase 1, which is still ongoing. We made the decision to leave that survey open and ongoing so we can still get a lot more respondents. And I'll tell you why I made the decision to leave that open. So essentially, this was an online survey administered through REDCap, where individuals can kind of they can just click the link, fill out the screener, and complete the survey. And it's a pretty lengthy survey, as you can see. Like, there's multiple different things that we're asking of individuals, and different measures and scales that we're asking individuals to complete. And we were incentivizing individuals or family members with about $25 to complete the survey. So here's a little bit of participant demographics. We've had 135 respondents to this survey. The mean age is 51, about 51 years old for family members that completed. There's a majority female sample. As you can see the racial and ethnic makeup of the respondents that have completed the survey. This is really the main reason why I've decided to keep this survey open, is because of the 77% of white family members that have completed the survey. And so what we have made now and what we have done is limited the recruitment of white individuals to complete the survey and have just opened it up to distribute it, and again, really having a call for racial and ethnic minority family members to complete the survey. And we have also increased the incentive or the compensation that they would receive for completing the survey. So the majority of respondents were parents. It was recently brought to light by one of the providers and program directors of our coordinated specialty care programs here, is that family members sometimes is just not inclusive of individuals that actually provide support. And so he suggested that we use the term support persons, because as you can see, even though 75% of individuals that completed this survey were parents, this was immediately followed by siblings that had completed the survey. Significant others also had completed the survey. So about 10% of siblings have completed the survey as well. 52% of individuals currently, at the time when family members were completing this, resided with family members. And in terms of their loved ones, their mean age was about 27 years old. And as you can see here, the majority of the sex of their loved one were male. An interesting point to point out is, because we're looking at pathways to care, the mean number of hospitalizations for individuals that were reported for their loved ones was about 4 hospitalizations across a sample of 135 respondents.
And Dunni, just a quick question. This is the samples are being drawn from people participating in specialty coordinated services, or
Both.
is it more, so both, or it's more broadly?
Yeah, it's more broadly. So originally we started out as just really targeting individuals that are currently participating in coordinated specialty care programs. Mm-hmm. But I think you have all of these ideas when you come up with a study, and then you run into all of these walls that you didn't really anticipate happening. Mm-hmm. And so some of those things just had to do with logistics of funding that was happening at the same time within this specific population in coordinated specialty care programs. And so what we did was we expanded that inclusion criteria to include any individual that had participated in coordinated specialty care programs that have since left or have completed. And then we did another expansion again, because it's been a little over a year since this survey has been deployed, where individuals can complete it. We expanded it again to include individuals that may not have received early intervention, may not have received coordinated specialty care programs, but received some sort of intervention for their loved one. Right. And so the questions were really tailored around, even if the individual was now a little bit older, because as you can see, like the mean age of their loved one at this present point is 27 years old, and about 52% lived with a family member. We had them recall back to when your loved one was in the early stages of their psychosis. And so a lot of the questions had to be tailored and a little bit altered to thinking back, like if your family member was not, or if your loved one was not participating, thinking back to the early stages, what were your experiences? And please answer these questions and these scales in terms of thinking about the early stages of psychosis for your loved one.
Thank you.
Yeah. So,
sorry, just a quick question. You mentioned raising the incentive. Did you have any trouble with the IRB or anything on that? Or that question has come up for us during COVID, as things are particularly tough for folks right now, and wondering if we have to up an incentive.
No, we didn't. I don't ever really have problems with my IRB. And if I do, I usually pitch a fit. I stop sending emails and I call, and I keep calling. But originally it was $25 to complete the survey, and we bumped it up to $40 for the survey completion. I think they would have maybe given me a lot of pushback if I bumped it up to $70 or something like that. So usually when we get over $50 is when we have to start making a more justification as to why it is we're providing this amount in one sitting.
That's helpful. Thank you.
Yeah. So in the survey, I kind of listed out the multiple different components and the different scales that we had on the survey. One of them was really having family members describe their mental health timeline for their loved one and their experiences. And I actually thought this was really nifty that we included just an open text box for individuals to put in a year and a month, and then describe what had happened. And so they're just recalling back all of the experience that they may have happened. And I'm pretty sure it didn't capture all of their experiences, but it really got to the gist of the important things that kind of have stood out for individuals. And so when I took a look at that data, and I really honestly thought that a lot of family members would not complete this, but they went into so much detail and information for what it is that they provided, that it is just really interesting. And so these are some of the things that kind of came about it, and how I decided to put it up as a figure. When looking at the dates that individuals provided, it looked like their pathway to care was anywhere as short as 2 months to up to 6 years. And I do believe that the ones that, the individuals that reported this extended pathway to care were probably some of the older individuals prior to coordinated specialty care programs. And so really this is a pathway, and the reason why the title of this presentation is to mental health services, because it encompasses individuals outside of coordinated specialty care programs, but it's still really focused on early psychosis and experiences related to that. So the catalyst, usually the first time point for what they provided was there was an awareness of other symptoms that weren't particularly related to psychosis. So it was an awareness of symptoms in terms of, I think one family member described some things had changed. They were acting differently. They started to exhibit high anxiety, or I noticed that they were depressed. Or it started with hospitalization. Hospitalization was the catalyst. Other family members went into very specific detail to even include my loved one graduated from college, parents had to fly out to exactly where it is that they were, and then hospitalization. And so you're really kind of capturing what was the catalyst for individuals for them to realize, hey, something is going on with my loved one, and this may be the early stages of psychosis. In between that time, where we're going to spend a lot more time as I move through this presentation, is the most frequent things that came up was the multiple hospitalizations that were occurring. And it was also the multiple diagnoses that people were experiencing along their pathway. They would start out with, I went to a provider and got diagnosed with major depression. And 3 or 4 months later, that diagnosis was then changed to, I have schizoaffective disorder. And then it was changed to psychosis. And then it was changed to something else. And so there was multiple things going on, which just leads you to think about the level of care it is that they're providing, the level of understanding, and how difficult it is sometimes to really diagnose someone with a schizophrenia spectrum disorder. And so we see these multiple diagnoses, and then we see a change in diagnoses along the way. There were several individuals that were highlighting interaction with law enforcement in 2 different ways. Interaction with law enforcement because the loved one got in trouble, or it's because the family member had called law enforcement because of violence, or because of something that they weren't able to manage within the home. So that interaction with law enforcement was 2 different things. Ones that family members were actually experiencing where they were the ones to call them. And then the other one was because something had occurred and the loved one got arrested. So those were kind of the experiences that were happening in between the 2 to 6 years. The other part of that, and I think the most important part of that, was the interaction with informal and formal sources for supporter services. We had a lot of individuals report, I went to my priest or my religious leader or my spiritual leader. I went to a psychiatrist. Immediately when I noticed these symptoms, I went directly to a psychiatrist. And so in my next slide, I'm really just going to highlight what a pathway or a particular pathway looks like that's combined with the informal and formal sources of support. So the most common one that was referred to as the first contact was family members would go to another relative. And this leads me to believe it's either A, individuals or family members went to another relative because they may be more familiar, or they went to another relative purely for support because they did not know or understand what was going on with their loved one. The second type of contact included a mixture of mental health professionals and informal sources, where we have, from there, they went to a mental health professional, or they went to a spiritual leader or a school counselor, or they went back to another relative or a family friend or a primary care provider. And I think what I found most interesting in this, when family members were providing who their second level of contact was that mental health professionals and primary care doctors really stood out to me, because the rest of them I would categorize as informal sources. Especially in a lot of coordinated specialty care programs or early intervention programs, we don't see referrals from spiritual leaders. We don't see a lot of referrals from school counselors or school personnel. We do see a lot of referrals from family members. And so really kind of understanding that, especially as you start to think about what are the points within this pathway of care can we leverage to intervene. So we reduce the number of contacts. So we reduce that pathway to care so it doesn't extend into 6 years. And as I mentioned in the maybe the second slide, the duration for untreated psychosis, which is that pathway of care, is about 12 months within the US. So then we have the third level of contacts. I think what was interesting, some individuals went from informal source to informal source to informal source for levels of support. And so it may not be that family members are really, I think they're looking for services, but I think what's important to them is having that support. And I think using this information to kind of plug it in and think about it in terms of the previous slide, it kind of just builds on to really understanding what those pathways looks like, the complexity of those pathways, and how individuals end up in outpatient mental health services or even coordinated specialty care programs is very complex. But I think what we can derive from this is that we have a ways to go in terms of thinking about tapping into formal sources, which is our mental health providers and primary care providers, and educating them more on how to diagnose and how to assess for psychosis, and how to identify signs and symptoms. But we also need to make a concerted effort with also looking at these informal sources, especially as in terms of support, so individuals can kind of access care a lot earlier. So the next measure I'm gonna talk about is the barriers to treatment participation. And so for this, I use the barriers to participation scale that includes 4 different subscales, and then the second section includes information about critical events. And so the first section is stresses and obstacles, and it includes 20 items. The second section subscale is treatment demand and issue, which includes 10 items. Perceived relevance and treatment, traditionally that includes 8 items. We actually added an additional item to that, to the survey. That would be included in that section. Relationship with the therapist is the 6th item, and then critical events was the last section of that. Subscales 1 through 4 are rated on a Likert scale of 1 to 5. And then subscales 5 is just rated on, it's just a yes or no responses. And so I dichotomized that Likert scale just simply as a yes to no, because 1 is never a problem, and we mark that as no, and then 4 through 5, I identified that as a yes, that was a barrier. So looking at the first subscale, these were the responses, and these were the most heavily responded items in the entire, or some of the most heavily responded items in the entire scale, where family members, 75% of family members said that during the course of their loved one's treatment, they experienced a lot of stress in their life. Which was followed by, my child refused to come to sessions. And that was one of the biggest barriers, and that is still another barrier for coordinated specialty care programs. The next subscale was treatment demands and issues, where the highly responded, or the highest responded, what families highly responded to was the scheduling of appointments times made it hard to attend, which was closely followed by, I had trouble understanding my loved one's treatment. When we go into perceived relevance of treatment, 54% of individuals said that my loved one has a new or different set of problems, followed by the session did not seem to give me what it is that I needed. And then 4, relationship with the therapist. And this one, when I was looking at it, I slightly chuckled at, that the therapist did not call me enough. The therapist did not seem confident that my treatment would work for my loved one. I did not feel the therapist supported me, and I simply just did not like my family therapist, or the therapist that was working with my loved one. In terms of critical events, family members on average reported about 2 critical events happening along that pathway to care. Where about 30% of individuals said my loved one was put in inpatient or residential program, which hindered their participation. And then that was followed by about 25 or 26% of individuals said participation took away from spending time with my family. And then my loved one moved out of the home, or there was an alcohol or drug problem in the home, or medical insurance did not cover treatment. And those were about 20% of individuals said that that was a problem to participate in. And so to summarize all of that, because that was a lot, essentially, these are the things that I took away from the responses to that scale. In terms of obstacles, which were more, there were more stresses and obstacles that compete with treatment more so than anything else, where the loved one's engagement brings about a new set of problems that are important, where the scheduling, there was scheduling conflicts, which limited participation. And I think that one's pretty common, not just to early psychosis, that one's pretty common to mental health services and engagement anyways. There was a combination of stresses that included the loved one's lack of engagement and other life stresses that were barriers to treatment. Related to treatment demands, it was confusing, and there was a lack of clarity about treatment and materials that were provided to family members. They felt excluded from the decision making, and then scheduling also came up in treatment demands as well. Related to treatment relevance, expectations were not met as they were described, and even after the first meeting, family members had the first meeting with a mental health provider. And then there was a lack of adaptation to new issues that the loved one was experiencing that brings about additional needs. Because as things change and adapt while an individual is living within the home, you would want to think that that family psychoeducation or that family component or even therapy would adapt to those new changes that are happening and not just what it is that brought them through the door. In terms of the relationship and interaction with therapists, that was impacted by inconsistent and infrequent communication with family members and feeling supported. And I think what I took away from that, a lot of these things are kind of intertwined. Where some of the demands is going to affect the relationship with the therapist. Some of the demands are also going to affect treatment relevance. And so the biggest part of that, when we take a look at critical life events and how that impacts treatment, is that family-related circumstances are also impacting not just what's going on with that family member and the loved one, but in addition to the larger family unit. Whether there is a substance use problem that's happening, whether there are other children within the home and it's taken away from spending time with other children and participating within the family circle. Living environment is impactful. We know that when a loved one, especially youth, live with their family members, that engagement is a little bit higher. But it's also the engagement of the loved one. What I hear about in a lot of coordinated specialty care programs is that the loved one may not want to be engaged, but the family member is still yearning for some type of family education. They still want to participate. And that's really hard in terms of when you're thinking about coordinated specialty care programs or early intervention programs are really built for the loved one, for the youth, for the individual. And so if they're not engaging, how do we then still provide services for the family member who technically is not a client? They're receiving the additional support because their loved one is a client in treatment. And so when you package this all together, this is what it kind of looks like. Well, this is how I envision it to look like and how I put it together. In that things start out as an awareness of symptoms and hospitalizations, followed by more hospitalizations and diagnoses and a lot of information coming in and out during that pathway. And it includes multiple contacts with mental health providers and mental health services. And it includes multiple contacts with other places for support. And these can be positive and negative experiences. And really these positive and negative experiences that happen really impact engagement. It impacts engagement during that pathways to care. And it impacts engagement in that initial first session in early intervention programs, which also then impacts continuous engagement. And so it really highlights these 2 points that we really need to focus on in terms of intervention. Initial engagement is one thing, which is directly influenced by how individuals matriculate into that program and move into that program. And then continuous engagement is another issue that we would need to focus on in terms of family engagement. As you can see on the, I don't know if you can see my mouse, all of these things impacted as well. And these were the barriers to participation. But I think the nice thing about looking at it in terms of this is that these things can be addressed. We can improve consistency to build relationship and build rapport with a therapist. We can make sure we're addressing family needs and expectations by understanding what their family needs and expectations are. we can make sure that we address the stress, anxiety that family members are experiencing, and not just provide them with, these are the signs and symptoms of what early psychosis is. This is how you can manage symptoms while you're at home, but really addressing other stresses that may be impacting the family members' engagement, which also then would subsequently impact the individual's level of engagement and outcomes along the way. And in terms of treatment demands, making sure we're providing adequate resources, adequate services, describing them in a way that individuals and family members truly understand the level of treatment it is that they're providing, truly understand the expectations from them, and how these expectations impact treatment goals or treatment outcomes that family members and loved ones have. I think in terms of thinking about treatment needs and level of involvement, family members' goals are often very different from individual level goals or the youth level goals, whereas their goal may just be, I just want to get a job. I just want to go back to work and go back to school. But the family members' goals are actually sometimes quite different. And so how do you manage that in early intervention programs? And some of that just includes beefing up our models of coordinated specialty care to address those things, and providing additional training to not only these mental health services and providers within these mental health services, but also within these informal sources of that individuals tend to seek out in terms of what it is that they're looking for or support it is that they need. And so, yeah, that's it. That's the end of my slides. Thank you.
Excellent. Excellent, excellent, excellent. So I have there's a couple of questions that have come in as you were talking, Dunni. This is really good. So I have one first from Daniela Tura, one of our doctoral students. You mentioned this was earlier when you're talking about the hybrid, all the different types of coordinated specialty care and the different hybrid models. And her question is, what are, you mentioned some of those components, and if you can discuss some of those, and what are some of the decisions that people are doing for how to package those coordinated specialty care? What is included? What goes into those decisions for making those services?
Okay, I'm gonna pull that out of my slides so quick.
That's okay.
So I'm gonna pull it back up so people can see what it is that she's referring to. Back. Okay. So you said the first question was how are
what are the
programs?
Components? Yeah.
Okay, so traditionally, so these are the components that Washington State uses in their coordinated specialty care programs, and they're very similar. And so a lot of these components are also evidence-based treatments, where family psychoeducation is an evidence-based practice. And so essentially, and supported education and employment, I think in other terms, that's individual placement and support. That's an evidence-based practice. And so a lot of these components that are some of the bigger components, and as you can tell, like some of these bigger components, they're just bigger in terms of the frequency, is that they're putting together things that they know work. And that is how they're determining. Now, there are differences in terms of different models. So essentially, Navigate, the model that I was describing to you earlier that was funded by the National Institute of Mental Health, did not include peer support. Mm-hmm. And it did not include case management. These are like peer support, case management are elements of On Track New York coordinated specialty care model. And so even though we started out as a Navigate type of model, and why we now say we're a hybrid is because we're incorporating elements based on need. And we're incorporating elements based on things it is that we know work and have worked in other programs, or is based on our specific population. In Washington State, there was a really big call for using peer support, where now that has also extended into using family peers. And so some of those things are being added onto, similar to a nurse role. a nurse role is not traditional to coordinated specialty care. But when you think about the implementation and when you think about what works within a given agency, it makes sense to include a nurse in that, just because of all of the physical health problems that occur with individuals diagnosed with the schizophrenia spectrum disorder. And so those are the decisions that get made. And I think those are the decisions that people kind of pick and kind of analyze. What does our population need? What do we see the most? And kind of adapting from there and adding additional elements.
And they're picking, if I'm understanding you correctly, they're also picking these elements because individually that element, there's evidence to help in this population to address symptoms, engagement, and other outcomes, that they have quality of life and things like that. Yeah. What's interesting in this area is that we have an RCT of Navigate that is one bundle of services, but then we have others. We have 300 other, in many ways, that are configurations of Navigate or On Track, but we don't have an RCT with all of those. So it's a really interesting sort of, based on, if I'm understanding correctly, based on the evidence, but also based on the local need and how to make that fit better.
How to make it work,
I see. And then there was another question. I think this has to do with the racial makeup of your sample in the survey. The question will come from Kelsey and say, do you have the percentages for the racial makeup of people receiving services? And in a sense, what you have here is our family members of people who receive services, right?
Yeah, I do. I haven't looked at it, but I find that interesting because it also seems like, and I never think about this, because I have them report on that. I have them, what is the race and ethnicity of your loved one? I have the numbers, but I just didn't put them in the slide.
Yeah, I put it in that. Got it. You know, it's really interesting to see some of the things that are emerging from this survey in terms of the family members concerned. Like, it's really telling to say family members feeling confused about the treatment as being provided, not understanding that treatment, and also not feeling very secure that the treatment might work. And it's really telling that there's something there about the importance of the provider and the family member really communicating and being very open about what's being provided and what's the limitations of treatment in the situation. So I think there's a lot there. There's studies that have found that as a really important element for engaging families in that level.
Yeah, I think that part is really important. There was another question, and I presented in a different presentation that's just pulling out the racial and ethnic minorities out of this data, where we're looking at what resources did you get. So even if you didn't end up at the appropriate place, what type of resources did you receive? Did you receive resources on suicide prevention? Did you receive resources on early intervention programs? And I think for the racial and ethnic minorities in this sample, 50% said they did not receive any type of information. No information related to symptoms and signs, no information related to substance use prevention or additional support services within that community. And so it's just, I think that speaks a lot to individuals' experiences and them coming away with absolutely nothing, no clarity, no additional resources, no support. And I think that impacts engagement. And I think in terms of everything that we do, why wouldn't it impact engagement? Our experiences are going to shape how much we are actually going to engage in something, or how we're going to receive what it is being presented to us.
That's right. That connection, that first connection interaction is so important, because and because of that, and also it could engender mistrust. Like, if not providing information, not helping, could really impact whether someone will come back to care. That's really important. Other questions? I know that you can use the chat box as well, or unmute yourselves and ask the question. Other things that come up.
Yeah, kind of on that same topic, I was wondering if there's evidence to support maybe adding a support group for loved ones into the services provided, and if there's like evidence that shows that impacts engagement at all.
I don't know if there's evidence for that. I know that so I'm gonna speak to Washington State. What we've seen in our programs, and this is where it's really hard to be consistent across programs because they're not all provided by the one agency that we see, right? So we have 9 different programs in Washington State, and I think 5 different agencies implement these programs. And so what we're seeing is that some providers and some programs or agencies are developing support groups. They're developing support groups for individuals that may not have been eligible for services because there is such a strict eligibility in terms of receiving early intervention services, where they're creating these additional support groups where they can attend, or they're combining it with family members that are not a part of coordinated specialty care programs, but that are just seeking support. So I'm not sure about if there's evidence out there, but it would be similar to NAMI has it. Like sometimes we refer individuals to NAMI if they need some additional support and to make connections with other family members. We send them to family. And so I don't know if there's actually been concrete studies done on that NAMI support services that they provide, but that would definitely be something interesting to look at. And I think it's something that is important because a lot of people use those services.
Thank you.
Yeah, no, thank you, Kelsey.
I have a bit of an ignorant question. I was in Philadelphia when they were talking a lot about sort of recovery-oriented systems and that notion. And it seems like some of what you presented touches on that, and particularly what Leo commented on in terms of not believing that the treatment will work. Or I just wonder, broadly, whether patients and family members have a sense of sort of, possibility for recovery and how that's conceptualized. And I don't have a super specific question other than like, can you kind of comment on that notion and how it's integrated in your work?
Yeah, so that part is, I think, the most interesting part. I think that in this area, we focus a lot more on what's going on in treatment. And we aren't really looking at longitudinally when people graduate from these programs, what does that look like? I think there was a recent meta-analysis that came out that individuals' progress and the impact that these services made for individuals were not sustained after they left treatment. And so now you're looking at, well, what does a step down approach look like in order for that to be maintained? Because I think we stress that when individuals graduate from these programs, that we we connect these individuals with a consistent person that they can go to, a provider that they can go to in terms of needs, in terms of if a relapse happens. Because if a relapse happens, then they're actually not eligible for new journeys to receive those services again because they're not in their first episode anymore. And so I think recovery in terms of what that looks like is directly linked to what it is that we provide individuals. And from my standpoint, I don't think that we provide individuals a lot of support after they leave treatment. I think because they can, in our program, but there's more, they can receive treatment for up to 2 years. And then at that point, now we're starting to think, what does the taper down look like? How is it that is it the entire 2 years that they need? What are the markers for, because some people spend 6 months in the program and then they graduate. So what is the criteria for what that looks like? And some of it is based on psychosis severity and symptom severity. And some of it is also based on, did they actually meet their goals? Like we've got a handle on their symptoms. They've got a handle on it. Family members feel like, they've got it, but did they actually meet their goal? And maybe one of their goals was, I just want to get a job, but we haven't been able to successfully keep them within a job. And so I think that recovery, the term recovery, can encompass so many things. And I think sometimes we're very limited in just thinking about their symptoms. But if we're thinking about their quality of life and we're thinking about their functional outcomes in order for them to maintain and sustain throughout life, a lot of that is connecting them and making sure they have support if they need support, but providing them with the skills to do that. And so in terms of, I think it just includes so many different elements to it that I think that's a big part of this area that has been lacking, because it's really hard to track once they leave a program. I'm pretty sure like if we were tracking that, like our attrition rate would be up there. Yeah.
Thank you.
Yeah.
It's a great question. And I have another question here from Julie asking, did you ask any questions to ascertain the family members' knowledge about mental health issues before there were any signs or symptoms in their loved ones?
No, I didn't. I didn't ask that, and I wish I did. Yeah, that's a good one. But I'm sorry, Julie, but I didn't ask a question about just about like their educational level in terms of like health literacy, in terms of knowing what to look for as signs and symptoms, and whether or not they felt like that increased over time. I didn't ask that.
Yeah, that's a good question. Understanding before what is the knowledge that family members have before this happens, and what I think that'll be really interesting. And we know of some work that's trying to increase mental health literacy, psychosis literacy in particular communities. Steve Lopez works in that area. You know, going back to the question that Byron talks, and something really important, that this whole system of care is for 2 years, and then the system is basically telling these people, you've received this really comprehensive package of services, and now we're going to put you back into a service system that many times do not have any of these other services, like supportive employment, for example, is a good one, supportive education and things like that. So this is a real big area of work of what happens. We get these people to a really good place if they are engaged, but then we drop them, and it might be in a really critical area where people are making progress, and they might need what's the next extra level of help that they might need?
They might need.
Yeah,
I think that part is extremely important. Like when we started out our New Journeys, it's called New Journeys, our coordinated specialty care program, we started out, but I think the nice thing is that we've been able to make sure our program is flexible and to make adaptations along the way, where we didn't have a criteria for what it is that's when someone graduated. Instead of just basing it on, well, the provider felt like they were ready to graduate, or they hit 2 years and they were ready to graduate, where now we have like a cutoff, and we use a KP15. It's a cutoff for psychosis experiences as a determining factor. We also look at, did they actually meet their goal, and are they ready to graduate? And these are just questions that we would ask them. And then we take away services. And so instead of meeting with the individual therapist and getting the whole wraparound type of services, we limit that to once a month. And then we ask them a question again. Are you ready to relapse, while still doing the KP15 measures along the way? So if they score above that cutoff, then we're providing the services again. So we kind of give them this 3-month trial run of what it would look like if they were only seeing a therapist once a month. How are they doing in the home environment? How are they doing with the work employment environment? Are they able to manage and maintain? And if in those 3 months they aren't able to do that, or they don't feel comfortable yet, then we provide the services back.
excellent.
And that's something that we've just been able to do, just because we've been able to adapt and be flexible with our program and have it disseminated to all 9 of the sites at the one time.
Very interesting. So, Dr. Oluwoye, this is great. Thank you so much for your time today and for this talk. We're at the end of the hour. I just want to remind people, our next seminar will be on November 18th from 4 to 5 p.m. Central Time. We'll have Dr. Kiara Alvarez, who will present early interventions for suicide risk among Latina immigrant youth, bridging clinical, family, and social context. So we would like to thank you for a great talk, Dunni, and thank you so much for your time, and thank you everyone for participating today in our seminar, and have a good rest of your day today, and take care.
Bye.
Thanks so much.
Thank you.